Hello and welcome to another Polestar Pilates Hour. Today I have a very special guest and friend of mine, colleague of mine, Beth Kaplanek. Thank you for joining us today, Beth.
Oh, I'm happy to be here.
Well, we got lots to talk about and you have lots to share. You've been busy the last 6 months. This is a very personal webinar. To both Beth and I, we were just arguing over who has more titanium in their bodies. But we are both, trying to be the bionic man and woman in the next couple of years. But seriousness, Beth has recently had a knee replacement about 6 months ago, and in preserving your knee, you had a fall, and you reached out and actually fractured your wrist. So. Not only was it enough to have the knee replacement, which is a very involved orthopedic surgery, one of the most involved, but you also had to have an internal fixation and reduction of the wrist fracture. So it was a surgical procedure in the wrist. And I saw you a couple days after that, and you just blow my mind of how tough you are. I think you're one of the toughest people I know. But one of the best teachers of Pilates I know. So it's good to have you on.
Thank you.
Beth also recorded a number of videos at different times of her rehabilitation and sort of showed some of the Pilates exercises or adaptations she made to regular exercises with the Pilates equipment, how she used the springs and the carriage and the tower bar and the foot bar to be able to continue to restore range of motion and strength and function in her left knee. Beth is also the author of one of our leading continuing education courses that looks at it's an orthopedic course basically for arthritis of the lower extremity. I'll have her tell us a little bit more about that at the end of the program. So we're in good hands today. We have good information to share with you, and we should probably just jump right in. Beth, tell us a little bit about sort of just a brief summary of your experience and how this event has been for you. You've been through 2 hip replacements. I've been through 1.
Right.
My understanding is that those are cakewalks compared to the knee, but I would love to hear from you and have our guest hear from you a little bit about your story and, how you're feeling these days and what your goals are, kind of thing, pertaining to the knee surgery.
Well, first of all, I'm really excited to be here and share. Whenever you're like hanging it all out, by letting people know exactly what's taking place, you're really talking about some personal things that you're going through. So I want everybody to be aware that I'm really comfortable sharing this information because I learned so much from my experiences. I thought I knew a lot after the 2 hip replacements. And just to segue back, I did have a water skiing accident when I was a young kid, and that sort of set up the system for an alignment issue that migrated down to the knees. I think I could have saved my knee from surgery, potentially if I hadn't had my meniscus repaired by an inferior doctor, but that's a maybe. Nonetheless, it's a bygone. So nonetheless, I needed to face the fact that I needed a knee replacement. And even though I function at a very high capacity, as Brent said, I'm a little tough. I was an athlete as a child, so I just kind of keep that same mentality going because I love to work out. I love exercise. I love what it does for me. I love the way I feel. When I found Pilates, I fell in love, and the rest is history. So 1 year ago, Brent, you and I talked about finding the right doctor for our knees. And I said in a webinar that I think I found someone that can help me with the type of knee replacement I'm looking for, even though you and I both know from all the literature, knees are tough. They just are tough. And you either have a difficult situation, an easy situation, or it can be a mixture of both. In my case, I really went through a lot of chronic pain with the knee replacement. I had it done July 25th at Hospital for Special Surgery with Dr. Haas, and the reason I chose him was because of the type of knee replacement he uses that provides some knee kinematics for the screw home mechanism. And I really was interested in that and really interested in getting back 130 plus degrees of flexion, which this replacement is touted as being. And so I went there. And from day one, I said after surgery, wow, I can barely flex my knee. I've got a problem. It just felt like there was something going on that was, I don't know, just didn't feel right to me. So I struggled during the post-op recovery of getting back my flexion because my muscles would rebound and prevent me. I'd get 90, 95 degrees, and the next day I could barely get 80. So I had constantly went through that pattern of difficulty of adaptation. And so I think when we show the videos, we can explain more of that. But now today, though, it took all of 6 months. I'd have to say I now feel I'm on the other side. And I've got my flexion coming back. I'm using some things to get there. Always had perfect extension. And my strength was always great. So I didn't have a strength problem. I had just the range of motion problem with the flexion and a lot of chronic pain because my body just didn't want to accept the joint replacement. So I was kind of a quandrum. I was a little bit of, wow, I expected that I would fly through it and then realized, you do not fly through the knee. The knee needs a lot of repair.
You've brought up a lot of really important points already, Beth. And I think, for anybody out there listening, and do a shout out if you're thinking about having a knee replacement or have a client that is having a knee replacement. But it's like there's so many variables. And you brought up a couple of them, which was finding the right surgeon, finding the right hospital, finding the right replacement hardware. To me, I mean, that's probably one of the biggest pieces. And, you're using a hardware that is toting the ability to maintain some of the normal arthrokinematics of the knee that we often talk about in Polestar, and how important those bone rhythms and those accessory motions are of the knee. The knee really dictates how the rest of the lower extremity works. And so when we lose bone rhythms, and it becomes a hinge joint, and that's all it is, which most of the replacements are, our tissues freak out. I mean, they freak out because they're wondering why they don't have a normal spin, glide, rolling kind of load on the capsule and the tissues around it. And so I think that's why we see so much challenge with total knees. But I think that's, you particularly chose hardware that is known now. It's relatively new, but it's known for being one of the few arthroplasties that actually focus on restoring some of those biomechanical properties of the knee. Talk a little bit more about how you were, searching for that, and what were some things that were particular to you that made you even think about a knee like that?
Well, when I first started looking for a surgeon, I went probably to 6 or 7 different individuals, and some of which you and I both know, Brent. And when they explained to me, well, you have like 125 to 130 flexion in your knee, you can expect to lose 5 to 7, 8 degrees of flexion postoperatively. And so you're going to live with, if you have 125, you're going to live with that 117 for the rest of your life. And I'm going, oh, wait a minute. Whoa. That doesn't work for me. That may or may not happen. But I wanted my odds to be a little bit better than that, And so when I found Dr. Haas and the type of replacement parts that he uses and the techniques, I went online and I studied his surgery. I actually watched his surgery. There's a videotape under Smith and Nephew of him doing surgery and educating other orthopedic surgeons. I knew that was the person I wanted to work with. And so that's why I went to New York and had it done there and stayed in New York for the first 2.5 months, recovering postoperatively, and did physical therapy 3 times a week. I can't tell you how important manual therapy is. The manual therapy was so important to me. It gave me such relief to have that, even though it was, quote unquote, your average PT type therapy, and that you're doing squats, you're doing your heel slides, the typical movements. Just having some manual therapy was really very comforting to me.
And it's interesting, again, a couple things, and I want to pull this out for the audience to understand things that, Beth is a very educated healthcare professional, being the patient and understanding, she's an educated consumer of healthcare practice, right? And understand how many surgeons would never talk to you about what apparatus they're going to use or hardware they're going to use.
Right.
They wouldn't talk to you about what procedure they're going to use. They're not going to talk to you about the pharmacology, both pre, during, and post. They're not going to talk to you about, a lot of them don't even refer you to therapy for a while. Like they just tell you to do your bent, heel slides and a couple of things at home that don't even prescribe rehabilitation, let alone this idea of having any kind of myofascial release or soft tissue mobilization, for example, to the quadriceps. And, the patella, if you have a resurfaced patella or not, the patella is having to reorganize itself with all the connective tissue around it, the capsule around the knee, if they preserved it or if they didn't preserve it. So there's all kinds of questions. And I think this is, in an age where we are really becoming educated consumers of healthcare, in general, of all healthcare, that it becomes very important that we become educated. That's why I know, that with Beth's course, and then I was asked to do a workshop for Pilates Anytime. But just, again, the more education that you can get from people who have either been through the procedure or have rehabbed a lot of procedures, like being able to get a good night's sleep. I mean, how long did it take you before you could get a good night's sleep?
Well, I think this week I had one night. That's when, and that's pretty typical. That's when your body becomes quiet. So you start to feel all the sensations, and you'll turn on your side. And and because of the kinematics of this knee on my side, you would eventually get throbbing. Okay, on my back. So I've been living on my back, sleeping. So if you're a side sleeper, it's a little difficult.
Yeah, especially side sleeping.
Eases. Especially side sleeping is tough with the knees, but you have to use lots of pillows. You have to get yourself comfortable, and but it comes if you have faith that it's going to get there. Now, when we look at the research, not everybody's happy with knee replacements. There's a good 10-15% of people out there that are not happy and continue to have pain.
That's not what the orthopedic surgeons say.
No, no, they don't.
You're right. I mean, the hip replacement does have a 95% satisfaction, but the knee is closer to 85.
Right. 85. It is true. 85. And there's so many deficits with just all the musculature that's involved in it. And the knee is it's a huge surgery. I don't want to even say that the hip is not. I don't. It's just that the way that you recover from a hip replacement is different than you do with a knee. So it becomes a very major surgery for the knee because the amount of requirement for recuperation, the amount of time that it takes you, the amount of therapy. I move every day because behind me is equipment. I'm on the equipment. I have my go-to movements. If I don't move, I'm not comfortable.
Yeah.
But it's been to my asset for where I am today. I've been back to work since I'm 9 weeks post-op.
Yeah.
And
again, when you say that, Beth, I mean, I think this is, people who do not push their knee are not going to have as much symptoms post-op either, but they might not have the end result of it. And so pain, unfortunately does not become the primary motive in rehabilitation of a knee replacement. I think that's where we often, we want to try to figure out how do we get pain-free in, this post-surgery. And we talk about I really didn't have any pain with my hip replacement, but I had a simple arthroscopic procedure of my knee 5 years ago that, like you said, it's just, and that's minimal. And it was much more debilitating to me than the hip replacement. So what I realized a lot of times in having rehabilitated many people with a total knee replacement is sort of finding this balance. Like, for example, with Beth, that you want to be back and this is my dilemma as well with the total knee, is that I want to be able to squat. I want to be able to kneel down. I want to be able to get on the mat and do Pilates exercises on the mat. And when I can't do those things, or I can't garden, right? Like for me to garden is a full, full squat, what they refer to with the heels down and the butt down. And I can still do that, but I have a lot of pain with it. The decision that I'm trying to make is, okay, I can get rid of that pain eventually, but I won't have the range to squat down and work in the garden. I'll have to bring a stool with me wherever I go in the garden because I won't have that 130 plus degree range with the traditional total knees that are out there. So these are a lot of questions people look at. Like I think of my mom and my stepdad both had knee replacements, and they thought they were the greatest thing since sliced bread, but they're not real physically active. They're in their 70s and 80s. And it's a big difference. Huge difference. As a matter of fact, just a quick one.
I can squat all the way down now. And I did TRX squatting and physical therapy. And I had actually one of the therapists stop me and going, only go to 90 degrees and back up, only go to 90 degrees. I goes, wait a minute. I'm not working on strength. I'm working on range of motion right now. And I need to get all the way down. So if my goal is range of motion, I'm going down. I'm going to have good hinging at the hip, watch my form, but I'm going all the way down. So, so traditionally, people don't look to be the athlete postoperatively, traditionally. But I needed to go back to full function and function. I teach all the advanced curriculum for Polestar. Yeah. And I'm not a spring chicken, but I have to stay tuned and in order. And my goal was to go back to full function. We're not going to go there. But thank you, Brent. But it was very important that I had strengths in the beginning. I went to the Canadian Rockies 2 weeks before surgery for my anniversary. We hiked everywhere. Going down, you could tell I had a complete deficit. I was bone on bone at 30 degrees of flexion. Going up, not an issue. But that was my deficit a bit during those early months of recuperation with this knee, is that my muscles were fighting me and I needed more myofascial work, needed more manual therapy. And then I continued with all the movements, which was very interesting.
I think, again, sort of looking and weighing out what we're looking for in the commitment. And one of the things that I tell my patients quite often, and you can, confirm or deny this, and I think we talked about it, was, when you're looking at total knee, you're looking at 6 months before you could say that you're really feeling better. I tell people, like, right, if you get it done earlier, that's fine. But it might also be because your expectation isn't to restore the level of range of motion that Beth was looking for, right? So if you're comfortable with 105 degrees, then you're probably going to have less symptoms earlier. Like you might be symptom free, or for the most part, by 4 months or something. But I tell most people, like, think 6 months and then a year to forget that you had the knee replacement. And so when I think of, stories that come back to me, people at a year out from a knee replacement can do pretty much anything. And it doesn't even really matter what the activity is. They can do, except things that require that last little bit of range of motion. Right. And so that's really that's been my concern. That's been my fear of moving forward with the total knee replacement, is because I want to maintain that. Now, here's the balancer, and then I want to start looking at some videos of you. When I had my hip replaced and I sat down with Dr. Juan Suarez, he was the last doctor. I, like you, I went up to HSS. I went to Chicago to see Berger. I went out to Colorado to see Matta. So, I went and saw everybody and came back to my hometown in Miami and found a surgeon who is very proficient, both doctors we know very well. Suarez is the one that I chose. And, Suarez sat down with me and he said, why are you resisting having a total hip replacement? And my answer was, because I believe in being whole body, I want all my body. And then he looked at me and goes, are you functioning wholly with the body that you have? And that was a big click for me. It was like, well, actually, no. My hip had gotten so bad that I wasn't hiking. I couldn't do activities outdoors. I couldn't even cycle. I couldn't cycle because my hip range of motion was so bad. And so it was a big conflict in my life of traveling and teaching Pilates and movement and having this hip that wasn't allowing me to move. And so he sort of shifted that switch to, well, are you more interested in having all your body parts or having whole body movement? And that was a real click for me of thinking, like, oh, I want whole body movement. I would love to be able to squat down again. I'd love to be able to go hiking again and do all these activities. And I made the decision for myself. He goes, well, it sounds like you made your decision. And I said, well, how soon can you get me on the table? And that was the decision. So I think when we look at these big decisions, and people always ask us, when is the right time? When's the right time to get a knee replacement? And, it's like when you can't do, and with the hip, we say 50% of your activities. With the knee, we say 75 to 80% of your activities, just because we know that the knee is going to be a longer haul than the hip might be, right? And I think that's a fair assessment. What are your thoughts on that, Beth, as far as, why did you decide to finally do the total knee? You move beautifully. You always take very good care of your body. You teach frequently and practice what you preach.
people that are movers are very good at camouflaging to some extent until you look deeper. We fake it till you make it, right? So to some extent, that's what I was doing. It wasn't that I wasn't living in pain. I just had enough strength that I lived with an average range of 1 to 2, maybe 3. If I went dancing, I had no quality of life with things that I enjoyed doing. Like I couldn't dance anymore. I couldn't go down the stairs comfortably. So it wasn't if, it was when. That's number one. And you don't want to go into a joint replacement completely debilitated. You know, when you go in that week, you may have an easier recovery because you don't have muscles guarding and things of that nature in that way. But to get back to a full function is going to be 2 or 3 times as difficult as we would see. I mean, there's people within the first year have up to 40% quad deficit to their non-surgical leg. And stair climbing and stairs ascending is still a major issue. And it's under patient satisfaction. That's one of the things, pain and being able to go up and down the stairs. Now, 2 things that I do that I'm really excited about. I'm going up and down the stairs beautifully, and I'm so excited. You know, like I can do front lunge on the chair comfortably. All of that's happening, mountain climber, all of that. And from day one, I've been on my knees. I made myself get on my knees, both of them, quadruped, and maintain quadruped position until my knee became adapted to being on my knees. And I can do kneeling arms now at 6 months, all kneeling quadruped work, whatever. That was super important to me, but you have to work on it. I've got plenty of clients that have knee replacements that don't want to go on their knees, or they're like, okay, how am I going to get there? Oh, let me think about that. No, you can do it. You can do it. So you have to train your body. And you need to know it's not if, it's when. And your quality of life gets to where you are not living your full quality of life and you're feeling older within yourself, that it's time.
Yeah. There was a statement that came in privately. Well, actually, it went to everybody, it looks like, on the webinar chat. And that was Pat Back. He made a comment. I don't know the gender, so pardon me if I misspoke there. But having bilateral knee replacement 6 years ago, and recently walked the Camino de Santiago from France to Spain, and that the knees worked quite well, was the statement, but still having struggles with things like deep squats or sitting on the heels. And that leads to the first question that's up here from Kay Halperin, which says, what about kneeling? And kneeling's tough, and you got to think of a couple things. When you kneel, typically if you're going to stand up from kneeling, you have to cock the toes underneath, which means that if you're maintaining verticalness of your femur, your knees have to be flexed to 120 degrees to be able to get your toes underneath, even to be able to do like a half kneeling to bring one foot up, right? So if you're at 105 degrees or 100 degrees, you're not going to get back far enough in that range of motion to be able to tolerate kneeling, which means all the pressure is going to be on that kneecap. All the pressure is going to be on the transition of the tibial plate that goes in and the tibia, because that's where all the torque is going to go. If you get a little more range of motion, then you can weight bear on the tibial plateau. That's where we want you to bear weight. We don't want you bearing weight on the transition of the hardware or the kneecap, heaven forbid, because that's going to be very uncomfortable. And that's why most people that have had knee replacements have a difficult time kneeling, is because they don't end up with enough it has to be in almost a relaxed range of motion. You never want to be at the very end of range of motion for a functional movement. So if you're at 105 degrees or 100 degrees flexion, right, that's just a little bit more than a right angle. That means when you're kneeling, you're at the very end. You're always at the end of the range, but you are having torque going through that replacement in that patella that is often uncomfortable. And that's why we see that so often. And, it leads to a whole bunch of other things, right? And this is why we want to get 120 degrees. I mean, I want to get at least 120 degrees in my clients with a standard knee replacement. And I'm happy with 120, 125 degrees, because I know now that they can do things like half kneeling. They can say their prayers at night. They can garden. They can do some of the functional things that a lot of people with knee replacement still are missing.
Right. It's about 105 to 113 degrees for just basic daily living activities. Just to get in and out of a bathtub, you need at least 130 degrees of flexion to get, and it's somewhat comfortable to be able to get on all knees and get back out. So I really love 120 to 130 post-operatively is like, to me, like key. And that was super, super important to me. And it still is. And I'm still working on it. And you and I are going to show something that I'm using now to increase that range of motion.
Let's jump into there. Melissa, why don't you bring up the early videos of Beth and let's take a look at them. And while we're looking at them, Beth, just sort of give us a talk over. We're going to keep the sound out of it so that you can just explain what we're looking at.
Okay. This is me in about 7 days post-op, and you can still see the surgical marks. And I was using, in New York, I have a tower reformer, and I was using a spring attached with a cuff, the thigh cuff, or the leg cuff, to help assist me into the typical heel slide that you will do post-operatively. And you could see it was very difficult getting 90 degrees of flexion. This was 7 days post-op. I was able to get 90 during this time, but I wasn't able to maintain it. And then this is a standing knee extension exercise, again, using the springs hooked to the tower, and to complete this work, bending and extending.
The extension there, too, is coming from the posterior hip and thigh more than it is from the quads. And so it's great to create that assistance for flexion, but resistance for extension. And that extension really is initiating a lot of it from the hip, which is what we want with any kind of knee surgery, is to get a little more hip extension involvement in that movement.
The asset to me is I had 100%, I had knee extension. So, and my hip extension is pretty good on my left side. So all of the resistance and assisted exercises were very easy for me to get full extension in standing and in laying down, which was a real asset.
And not everybody gets that. So I think it's important for people to know that you want to try to get that as soon as possible, the extension more than anything, because that'll affect your standing, walking, and locomotion if you can't get a full knee extension.
The other thing that I work very hard on is getting back my dorsiflexion, which is very important. And it affects your flexion of your knee to get that dorsiflexion. So doing multitude of things to work on dorsiflexion during my recovery. So I just want to cue that in. That's really, really, really important.
Yeah. And the other thing that's happening here is can you see the discoloration around Beth's heel? You know, typically with these kind of surgeries, they're very bloody, and the blood is going to pool down the leg. In order to be able to get the muscle pump to be able to reduce that blood, that dorsiflexion and plantar flexion are essential while you're doing your knee exercises very early on. And even sometimes just wiggling your toes and circling the ankles and getting them moving, even if you get them elevated up onto a wedge or a pillow, super important. And as we talk about Polestar all the time, we're talking about whole body. So it's not, we're looking at some very specific things here for Beth's knee, but it's important to understand, as she said, like you have to engage what's going on with the ankle and the foot and the toes and the hip, as well as, being able to get movement in your trunk and your pelvis while you're in this rehabilitation state.
In the first few weeks, you are on a blood thinner too, which increases the pooling down by the foot.
Exactly. And that's to prevent blood clots. So total joint replacements are famous for having some coagulation, and those blood clots can move up into your lungs, your heart, your brain, and cause a lot of havoc. So you always will see that blood thinner.
I think this is just about 2 weeks. This is feet and straps. This is just on the reformer. And I was just beginning to do feet and straps. And you can see the incision. Maybe this was 7 days.
This is 7 days still.
7 days. That's still the 7. Okay. Yeah, you have the list there, Brent.
Yeah, this is the one that I thought you were hanging from something and doing a Cirque du Soleil activity 7 days after your surgery.
Well, the bandage was off. He had taken the bandage off at that point, and the surgical marks are gone. So it was in that period, 7 to 8 days. So I was just holding my iPhone and doing feet and straps. And this was a go-to. I loved feet and straps. Footwork, not so much. You'll see tower footwork was my favorite thing to do, and feet and straps and leg springs all the way up on a light, long leg spring was awesome. And today it's still my go-to exercises. That's what I'll run and get on. That's what I'll run to do first thing in the morning to warm up.
Great.
And I did not know that until going to this. I wouldn't know that otherwise. But this the way the angle with the legs above you, like in tower footwork, with the feet, the legs up and flexing is easier than heel slides or in a supine position.
Yeah, I think it also has to do with the position of the hips and You know, if you're going to be in a little bit of external rotation, the hip is going to move a little bit further, which can allow a little more stress to come through the knee and work on that flexion in that position. So that's a good one.
And I was trying to get my hamstrings to work a little bit more here. I'm keeping the femurs relatively stable. I'm just hinging at the knees. I do that both in leg springs as well as in feet and straps.
There's a question on the amount of tension that you have on your springs here too, Beth.
Red and blue.
Red and blue.
Just 2 springs like you normally would use.
Yeah. So on the reformer, you're looking, she's laying on her back. The maple cabinets you see there are the wall.
I'm filming like this, guys. I'm looking up at my legs going,
I had to look at it a couple times. The next video clip we have is looking at 19 days. Beth, let's take a look at that.
And as you can see, I have better flexion and a little more control, less swelling, but I continued to use this because heel slides in therapy and me, even with the TheraBand, were actually the last thing I enjoyed doing. So when I added a spring and got the assistance from the equipment, it became so much more comfortable for me. So I could get up and then try to help it in just a little bit more, which I was just doing. So I found this to be a very comforting heel slide and not difficult. So
now here you're on the tower bar. On the tower.
Yeah. I'm on my tower. And now you can do tower either direction, right? You're either hanging out, you have to build up the back of it, or you have an extender if you're on your trap table. Start this way where you're laying down towards the tower, and then you can build in with more flexion, turning your body around from the other direction and getting a little more hip flexion and knee flexion.
While we're looking at this, there was a question, I think it was Whitney Vavell asked the question of just getting your feet into the straps on the reformer when you were getting on the reformer. Did you have any challenge with that at all, or was it pretty easy for you to get it in there?
No, I have good knee, hip flexion, able to bring my leg up high enough and bend enough that you can put on, no problem.
Right.
Or lassoed it. I don't know, maybe I was lassoing, but I don't think I was.
That's the cowgirl in you.
Yeah. But this was real. The tower footwork was very, 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 very comforting too.
And then there was a question on the springs with the tower bar. Was that 2 blue springs or 2 yellow springs? What were you using?
No, you got to be careful with this. So because you are limited in knee flexion, you need to use a long leg spring. And I was using one purple leg spring. And if I wanted to add, I added a yellow.
What about the tower bar one? The tower bar.
Yeah, that's the one. One purple.
One purple. Okay.
One purple, because you have to bring it up higher.
Yeah.
You don't want to start with your tower bar too low. If you use a short red or a short yellow, the tower bar is too low. So you
blocked your safety strap a little higher too, right?
Blocked it higher and then used the long purple.
Okay.
Exactly.
Got it.
And then as I improved in flexion, I brought it down and then turned myself the other way. Now I do tower footwork in the other direction, monkey. So I can get more flexion.
Yeah.
Exactly.
Very good. Let's shoot over to the next video. This is at 26 days out, and explain what's going on here. Because remember, we talked about whole body and how important other aspects of the body are, not just the knee. Tell us a little bit about what you're working on here.
So I love to do psychic series. If anybody knows me or works with me knows how important it is to do hip strengthening. And hip strengthening for knees is key. And in all the research, it shows if you have to do full body strengthening, but you must include the foot and the hip in your rehab model, especially when it comes to the knee. And so I every day would do my own body against resistance psychic series. Not using the assistance of springs, which was fine, but actually I was more comfortable because of the amount of torque and side lying on my knee to do it with my own body against resistance. So this is just me doing psychic series using the long box because I had the reformer out and I didn't want to set the tower up. So I was being perhaps a little lazy, but this actually increases your difficulty of balance too.
Let's jump into 6 weeks out. Seated footwork. So you're seated on the reformer.
I'm sitting on the reformer and I'm using probably one red. Ideally, I would like to use a red and yellow, but I'm certain I was only using one red at the time. And with a little bit more of dorsiflexion so that I could really pull my quads up and get a little of the tracking of the patella and increase that. Because I noticed that because of the type of approach, I had a mid-vastus approach, so they went to the vastus medialis, and that had to be repaired. So the tracking of the patella is very important, and you want to regain the strength of the vastus medialis. So sometimes it's inhibited after surgery, whether it's arthroscopic or arthroplasty. So trying to get all of that engaged. Now, seated footwork is a little uncomfortable, so that's why I added that in a little bit later. I didn't do it from the early beginning. I do it from that time zone and further. Now I do it all the time. But now I have a lot of flexion. I have much more flexion. I only had like maybe 105 at that point.
So there was a question from Sarah Edwards, and I want to make sure I ask this correctly. But Sarah, the FW you're talking about is forward lunge or on the chair. I'm not sure. Standing lunge on the chair, but you had a question about that. Could you just clarify what your FW stands for? Because I think we're at a good point to answer that question.
Standing leg pump on the chair is also another great exercise to do. And I didn't have a chair in New York, so I was using what equipment I had. Here, I use the chair all the time, all the standing work.
So she was referring to seated footwork. That was the...
Yeah, seated footwork, yeah.
Yeah, so seated footwork on the chair. She was asking the question if it's too much flexion or too much force on your knee at this stage of the game. Since you're able to do this here with a reformer seated on the foot bar, did you feel that you were just as comfortable working on the chair in seated position?
Okay. Double leg pump on the chair is what we were referring to. And you just keep the springs much lighter. And if you have a unilateral knee replacement, then you press the foot pedal down with the non-operative leg, then put the heel or ball of the foot of the operative leg on. I would start on the heel and then slowly work up to flexion and down. Okay. And you can then increase the tension and maybe just bring it up and hold it to where you can, count to 10, then press back down. And then repeat that rather than continuous. You see me doing continuous, but if you're working on building flexion, you need to go to a point where you can go, hold it, count.
Yeah, it was sort of like your Pilates Flexinator, which we'll look at the Flexinator in a little bit, but that idea of seated on the foot on the chair. Let's take a look at week 7 and your go-to exercise. Tell us a little bit about where you're at here, 7 weeks out.
Well, I wanted to do, I was getting ready to drive to North Carolina to the educators meeting, Brent. And I was leaving at 8 weeks, September 13th. Oh God, I remember exact the date we had the meeting. But I had to get myself ready to be in a car and drive that many miles down. And I had a new car and I wanted to drive it down. And again, I was testing my limits. I know that. So I was doing a bit of a flow, and you could see the springs were down. So I was using purple halfway down, not the yellows that I use for just getting my range of motion and feeling really, really good in the morning. And so you can tell I'm in a much better position at this point. I was 110 with the flexion, could get to 115, but really uncomfortable. But I was more 105 to 110 going towards and getting to 115 on certain movements.
Look at that
in
nice
certain
form.
Positions. Well, thank you, Brent.
Yes, the plank looked great. I like this. It's such a different load too. Doing sort of the jackrabbit and up that height.
It actually felt very comfortable. Jackrabbit felt really comfortable.
Nice.
The springs coming in.
All right, let's go and take a look at the last video of the Flexinator.
Okay.
And this talk a little bit about this device that you found and ended up ordering to be able to bring home and keep working on your own mobility increasing, and where you're at now with it.
Before I left for New York, I had an item called the Dynasplint, which it's like a brace that you put on your knee and you do heel slides down the wall. And I found it extremely uncomfortable and I didn't like it at all. And eventually I found, this was introduced to me at physical therapy. They drop it off for 60 days and I happened to be there and I tried it out and I fell in love. So I rented this and brought this home to my home studio. So this will take me up to 130 plus degrees of flexion. So it's like a hydraulic system. You take it to where you're comfortable. You hold it for a minute, and then you release, bring it back down, and you do like a 10-minute, 1 minute on, 30 seconds off, 1 minute on, 30 seconds off. Now I'm using it at a place where I could sit for 5 minutes, watch TV, people are really, really, really comfortable, and keep it about 5 minutes and then let it go. And then to bring it up to the next place, hold for 3 or 4 minutes, let it go. And then you comfortably get to where you've hit your wall and you know you can't go any further. Yeah. And you hold it there for like only a minute. And then you let it go.
And this, what I'm going to say now, will answer Ann Stallman's question that she has up there, talking about sort of the load on the hardware of the knee, and talking about the longevity of the prosthesis. And the reality is the prosthesis is fine. You don't have to worry about the longevity of the prosthesis. Where the inflammation, irritation comes from is going to be the surrounding soft tissues and the capsule, if the capsule's intact. That is typically going to sort of resist or fight the new hardware in the knee. That's why you might see the knee swell or get inflamed. And if you're also doing any kind of adaptation, and so this is something I want to talk about for a second here. What Beth is doing here is she is creating, when we think of myofascial release, if you remember being on with Carol a couple of weeks ago, and looking at this idea of sustained load on the tissue, right? And typically, we don't need to go too far. We can go to where we find that first level resistance, and we can stay there for a while. And if we can stay there for at least a minute to 3 minutes, we're likely to have the adaptation of the fascial tissues that are surrounding the muscle fibers, the ligaments, the tendons, the cartilage, everything that's connected there. And that's really the key. Some people that push it a little too hard. Now, like I said, Beth is on a mission. She knows what she wants. And so she's willing to disrupt the tissue to get that 130 degrees, which the hardware is capable of doing. Right. But the body is, in essence, it often is trying to reject the hardware. Like it doesn't like having a foreign body in it. When it finally gives up and it says, all right, I'm fine with this. I can see now that you're happy and you can do more activities. I'm not going to, be irritated anymore. That's sort of the paradise we look for with a total joint. But the reality is that any time that you don't keep moving into these ranges of motion, you'll lose that range of motion. And then you have to go back and do it again. Right. And so things like kneeling and quadruped and some of those kind of things, if we're not doing them frequently after the 6-month mark, the likelihood of keeping that range of motion goes back to the 100 degrees because that's what you're using.
You develop scar tissue very easily. Now, I heal very fast. So we didn't talk about the wrist yet, but I heal very quickly. And my scar, I can't even tell I have a scar. So I was worried about the amount of scar tissue was at the same rate, coming a lot faster. And so I did have an MRI at about 12 weeks post-op. I was really, really concerned that I was not getting my flexion. And it just showed moderate scar tissue, but everything was fine. Maybe I was just being overzealous. But I do believe you got to get in there and you got to create the adaptation. I feel that the constant hard work that you put, otherwise you're going to have to settle yourself with 110 degrees. If you want more, you have to work at it. It's not going to be given overnight. Yeah. And some people have a much harder time than others. Some people have a very easy time with this. They don't develop as much scar tissue, and others do. And I'm one of those that definitely does develop a little more scar tissue, so I had to work a little harder. So we got to keep that into perspective too.
Think of the spectrum of this too. So there are people who have much looser collagen in their body, more elasticity, and those that don't. There's those that scar more, as Beth mentioned, those that don't. And so there's a spectrum. What we want to be careful of is very early on, if you're somebody that's loose already, we certainly don't want to, push you to the point that you have hyperlaxity, right? We want to be respectful of what we really need to be able to do the activities we want to do. I always think of this in the dance world where, a dancer needs to be able to have a certain range of motion, or somebody in Cirque du Soleil does. But if they get more range of motion than what they need, they have a very hard time controlling it or having the power to perform. And so, this is sort of that fine line of looking at, what do I believe I should be able to participate in? What kind of range of motion do I need to participate in these activities? So both Beth and I have shared the sentiment that we want to be able to squat. We want to be able to get on the floor, get in and out of the bathtub. We want to be able to garden. That requires 125 to 130 degrees. So, if that is your goal, you're going to have more discomfort for a longer period of time, typically, especially if you have, quick healing and inflammation response. That's going to happen. Others might still, they're just loose jointed to begin with. I tend to be a little bit more on the loose jointed side, as you would say. So subluxing shoulders, subluxing hips, feet and ankles. Like I, tend to be a little bit on the looser side. And so I have to be careful to make sure that the tissue heals correctly to be able to maintain the control of what we would call the non-contractile tissues, or the ligaments, the cartilage, those kind of things, the capsules, to make sure that I can, maintain the integrity and the, the alignment of that joint dynamically. So everybody's a little bit different. That's why, I thought this was such a great topic to bring in. There was a question that was up, and I hadn't answered it yet, but it had to do with things like quadruped and kneeling exercises for individuals with, post knee replacement. It was Debbie Flanagan that asked that question. And, what is your feeling now, 6 months out, of your ability to tolerate a quadruped position, or what modifications are you making to be able to do a quadruped or kneeling posture, if at all?
Well, I don't kneel on the floor without padding. I don't kneel on the equipment without some padding, but I'm just to the point where I can get on the reformer or my tower without padding under my knees. But you have to start very early on creating the adaptability of that. Yeah. So kneeling on the bed, for instance, start by kneeling on the bed and then slowly progress to different surfaces. So you got to pad up and then slowly take things away. Today, I have enough flexion to be in a quadruped position very comfortably and go from quadruped to a plank to inverted V and walk, and then roll up. No problem whatsoever. But that was one of my desires. I, from the beginning, said, I will kneel. So mind over matter. That was very, very, very important to me. So I started from the beginning doing that. And Brent, you saw me at the educators meeting. Yeah. I was on the floor the whole time, right?
My mind was blown.
You have to be a little unique about how you're going to get up in the early days at 8 weeks off the floor, but it is doable.
You need a little Feldenkrais training to find alternative ways up off the ground.
Exactly. Now, I want to do a shout out to the Pilates equipment. I've had PT for 6 months. I just stopped the traditional PT. I did squats. I did the leg press machine. I did, TRX, various things, but there were just 4 or 5 movements and some manual therapy. What I can do, come home and do with the equipment, it blows my mind now after having a knee replacement, just how adaptable the Pilates equipment is to rehab and how important it can be for physical therapists to be using this arsenal of material to go well beyond what they usually have accessible to them.
Yeah.
And TheraBands and ankle weights and those things are all very, very important, but to have the ability to be more diverse, to get that full body function and movement was what was exciting to Dr. Jaffe when we wrote the book together.
Yeah.
That's what he loved about Pilates. So shout out to all of us as being Pilates instructors. And I know I'm talking to the choir.
Yeah, exactly. And think about the diversity that we can accommodate on the Pilates equipment. So we can eliminate gravity. We can change base of support. We can decrease or increase the length of the lever. We can, we can add proprioceptive challenges. We can modify positions. We can remove fear of movement with the things that we're doing. And those are all components that really can expedite the successful movement experience for somebody with a total knee replacement.
Especially the eccentric control.
Yeah.
We have that ability so easily on our equipment.
We can spend time there. There was a question about understanding resistance. And this is a physiological phenomenon, like how much resistance or how much pressure, overpressure. And, even with the machines, like for example, if I was doing footwork with somebody that just had their knee replaced, what I'd want them to do if I'm not working on stretching it, but I'm sort of working in a range of motion, is I want them to bend their knee or straighten their knee to the point that they feel the first little bit of resistance, and then move back and forth with that. And what will happen is if they can listen to that level of resistance, then you'll find that the range of motion gets bigger and bigger and bigger as you practice, because the tissues start to trust you a little bit. If you go too hard in the beginning, right, then it's the same thing with arthritis. And this is sort of best specialty in the education world. If you go, arthritis, especially osteoarthritis, loves to move. I mean, we feel better when we move with osteoarthritis, but it doesn't like being cold going to an end of range of a joint. It's gonna be angry. And so we start off with smaller ranges of motion. And the idea is, touch and go is what I often refer to with my cue, is touch the resistance and then move back out of it. Touch the resistance, move back out of it. Now, if you're working on stretching or increasing that range of motion, I go to that same point. And that's why I bring this up, is you touch that resistance, and then from there, you stay there and you breathe through that. What you'll notice is that the tissue starts to let go, and you'll notice you can go a little bit further. Rather than creating an irritation to the tissue, work with the tissue, right? And you still will probably have soreness the next day or two after doing that kind of, mobility work, because that is part of the healing process. What you're doing is causing a little bit of an inflammation process by changing the tissue lengths. And that inflammation process is going to bring in some of the, cytokines and chemokines and things like that that often are related with soreness. In the mending of that tissue, we're healing that tissue in a healthier range of motion. And that's where, Beth's whole point of, she has to challenge herself, and she knows what she wants, and she's definitely healed up by now. It's six months out, but she's going to have to continue to work on her own to be able to get into that final range of motion and maintain that range of motion.
I've actually had to learn to back off. Okay. Because you have to understand what your tolerance rate is. And that's going to be different for each individual. So you're going to study what that tolerance is. And that person's you're going to help your clients determine what their tolerance is. You're going to do X amount. And if that works and you feel comfortable from your normal modalities of icing or heating or taking your prescribed medications, your anti-inflammatories, whatever was prescribed or you're tolerant to do post-operatively, and keep that comfort. Then you add a little bit to that. Now, I was one who went too far, and then I would blow my knee up and I have to ice more because I wasn't sure what my tolerance was. I'd feel really great during it because my body gets really turned on with movement, but then I paid the price of that later. So I had to start paying more attention to my tolerances. And now I'm doing a much better job of that today. Much, much better job of that.
Very well said. Well, if anybody has questions, I do want to have you tell us a little bit in the last couple of minutes of the course that has been so well received. It sells out almost every time, and you continue to work on it. So even if you took Beth's course before, she always has new pieces and information and the latest research she brings into it. So tell us a little bit about the course that's coming up.
Yeah. I teach a course called the Pilates Teacher's Perspective of Lower Extremity Pathologies and Joint Replacement. So we talk about all types of knee and hip pathologies, and some lead to replacements, some lead to just learning modalities for improvement over time, like bursitis. That's not a surgical. But what do you do when you have somebody who has greater traumatic pain syndrome? And believe me, I've had it in the past, and I have had glute med tendonitis, and I know what that feels like, and it feels like you can't even walk. So how do you work with individuals like that? So all kinds of various pathologies for the hip and knee. And then we segue on the second day talking all about knee and hip replacements and all about the surgery. What is the anatomy of a surgical procedure? What is the anatomy of the hip and knee normal compared to a surgical device? What are my post-op range of motion guidelines? What should I be doing or not doing as a clinician? When do I get that client? If I'm a Pilates instructor, when do I get them when I'm a physical therapist? What can I do to adapt the equipment and make it happen? So it comes with a 220-page manual. Everything is photographed and videotaped. All movements are. And all the lectures are pre-videotaped, and then we also have it as a live streaming. So we do a lot of work.
So it's asynchronous and synchronous, meaning that you can study parts on your own and there's parts collective together and available to everyone.
Or you can take it totally asynchronously. I have it done where if you live in Sweden and you want to take the course, you can do it on your own time, and you have a month and a half to finish all the material because it's all been pre-recorded. But every time I do the course, I add new materials, so I have to add new videos to the learning library where all the whole course is. Yeah. It is a live streaming course, and we do the whole course live streaming, and you still are responsible to some things in the chapters on the video to do asynchronous. But for primarily the live streaming has a little bit of asynchronous and a lot of live streaming, or you can do it asynchronous.
And I can tell you that, Beth puts her heart into this work. I mean, she certainly doesn't have to do any of this or share any of this information with us, but she loves it so much. She loves teaching. She's a great teacher. It's why her courses always fill up and sell out.
You're so sweet, Brent.
I'm not sweet. I'm just being honest. And I am sweet. That's okay.
You are that too. But you know what? I have 3 joint replacements. I'm preventing the 4th one. I have titanium on wrist. And by the way, it was a high impact fall. I was trying to save my knees, and it was right after Ian, and I tripped over a light pole that fell down from the hurricane, and the lights were down and both feet got cut under, and I had 3 seconds to say, save the knee, and I went flying and took 100% of it on my right wrist.
And we forgot to talk about that wrist. Sport your wrist and show So, I mean, this was almost nothing to you going through what you had to do with the knee at the same time. So that was pretty impressive that, I mean, you were connecting springs with your left hand the week after the surgery. So again, that just sort of shows you the tenacity that Beth has. Want to thank all of you for joining us. Beth, thank you so much for sharing your videos.
I love being here.
And we love having you here. There are other questions that we'll have to come back. There's somebody asking about meniscus, and maybe what we'll do is we'll have another webinar talking about sort of knee trauma and some of the knee traumas that happen. This is more like what happens after you had the meniscal tear 30, 40 years ago, and you finally are due to have a replacement, and how we sort of get ready for that. So,
should you even have a meniscus repaired? That's another thing.
That's another thing. Yeah. And I had mine removed, and I never had knee problems before that tear. And now I have chronic, knee instability because of that. So anyway, we will put information into the post-production. So links to the course, links to information about this. Beth, anything that you wanted to share, you can share with Melissa, and she'll make sure it gets out to the community. Yeah. Thank you, everybody. And above all things, we just want to remind you to be kind, be thoughtful of others. This is a time where, again, it's still seeing the struggles that we're having in the world to be kind. And we should be the light to others and our patients, our clients, our families, our friends. Thank you, Beth, for your light. And we'll see everybody next week at the next Polestar Pilates Hour.
Thank you, everyone. Be well.